Hello beautiful people, you're welcome to my channel. I remain your host, 9ja-nr. In today's lesson, we'll be talking about pre-medications in anesthesia, what you may refer to as the goals, the importance, the objectives, aims and purposes of pre-medication, as well as the pre-medical drugs. But for the purpose of this video, we'll be making use of the word goals. By way of definition, pre-medication is the administration of drugs before induction of anesthesia and surgery. These drugs are usually administered between 48 hours to the immediate preoperative period prior to surgery. In current anesthesia practice, patients are pre-medicated with a purpose and not just as a routine procedure like it is done in the past. Before I go on, please, if you're seeing my face for the first time, do well to give this video a thumbs up, click on the red subscribe button, turn on your notification bell so you get to know when there is a new video on this channel. Thank you. We will start by taking a list of the goals of pre-medication. The first goal of pre-medication is to allay anxiety, fear, and tension. A second goal of pre-medication is to alleviate pain, that is, provide analgesia. Thirdly, pre-medications are given to reduce the chances of aspiration, like aspiration of gastric contents into the airway. Another goal of pre-medication is to reduce secretions in the oral cavity, especially salivary secretions and secretions in the respiratory tract. The fifth goal of pre-medication on my list is to reduce awareness and enhance amnesia. The sixth goal is to reduce post-operative nausea and vomiting. 7. To attenuate unwanted vagal reflexes and sympathoadrenal responses. Goal 8. To control infection. We don't have no infection, we don't go about treating sepsis and the rest, won't break down. No, it's a no-no for us. Then the last goal of pre-medication is to facilitate smooth induction of anesthesia and to reduce the amount of anesthetic agent used during surgery. Yes, now let's go on to talk about the pre-medical drug. To know the drugs that are used to combat some of these objectives, like the anxiety and the rest. Now for the pre-medical drugs, we have the anxiolytics, we have analgesics, prokinetics, H2 blockers or H2 receptor antagonists, butyrophenones, phenothiazines, antacids, B1 elective, adrenergic antagonists, anticholinergics, antibiotics, to mention but a few. Now we'll be matching the pre-medical drugs with the relevant goals. To allay anxiety, fear and tension, like to make the patient relax and less anxious for surgeries. Drugs are not always used for all patients. Yes, drugs are routinely used for pediatric patients. You know how they are children. They won't want to cooperate with you. There's nothing you tell some children that they will listen to. You are taking them away from their parents, going into a strange environment for surgery. So what do you have to tell me? Please, I need my mom. So that's just it. So for pediatric patients and patients that their anxiety was not relieved by psychological preparation by the anesthetist, we prepare their minds So for those patients whose anxiety was not relieved by reassurance, diversional therapy, assurance from their anesthetist, those patients should be given anxiolytics. Anxiolytics such as the benzodiazepines, talking about diazepam, lorazepam, temazepam, and midazolam. Very effective, midazolam, yeah. So those patients should get those drugs. This is because they produce some degree of sedation, anxiolysis, and amnesia, thereby facilitating smooth induction of anesthesia. Usually, the oral route is preferred with a sip of water, that is like the night prior to surgery or first thing on the day of surgery in the morning. To alleviate pain, like we don't want no pain, we want to be pain-free for surgery. This is especially for patients that are in severe pains. When I mean pains, severe pains, like those patients with crush injuries, yeah, so they deserve it. Then also it can be given to attenuate cardiovascular responses to laryngoscopy and intubation. Drug used here are opioids such as morphine, pentazocine, petidine, papaveretum, tramadol, and morphine, given intravenously before the induction of anesthesia. Now, reducing the chances of aspiration. Aspiration, we don't hear that. No, it doesn't sound nice. No, it's not a thing for us here. Aspiration can be very dangerous when the gastric content find their way into the airway. Lovelies, you find yourself in another world. So we don't want that happening. And this usually occurs in patients that are at high risk for aspiration. Patients at high risk of aspiration are commonly full stomach patients, such as those with hiatus hernia and gastric outlet obstruction, emergency surgery patients who are not adequately fasted, obstetric patients such as pregnant patients, and not routinely for all patients. So not all patients should have pre-medical drugs for this reason. The drugs include H2 blockers or H2 receptor antagonists such as ranitidine, famotidine, and cimetidine, which inhibit gastric acid secretion. Prokinetics such as metoclopramide, which enhances gastric motility by increasing gastric emptying time and thereby decreasing the volume of gastric contents. Also, prokinetics reduces the tone of lower esophageal sphincter. Also, antacids such as non-particulate antacid, like the freshly prepared sodium citrates. Others include the K citrate, B citrate, and magnesium trisilicate. Antacids increases gastric pH, thereby decreasing gastric acidity. Then there is also the proton pump inhibitors like the omeprazole. All the just listed drugs work to reduce the chances of regurgitation of gastric content into the airway. Reducing secretions, yeah. This is usually in oral surgeries where dry mouth is a requirement for surgery, and most anticholinergic agents causes dry mouth, such as atropine. Also, to attenuate excessive vagal reflexes that occurs during surgical manipulation, like stretching of the anal sphincter, traction on ocular muscles, and cervical dilatation, inhalation anesthesia, and repeated doses of suzametonium during laryngoscopy and intubation. The drug used to control excessive secretions are anticholinergic agents such as atropine, iosine, glycopyrrolate, and scopolamine. Reduction of awareness and enhancement of amnesia. Basically, drugs used here are used to produce good sleep, that is sedation, and to reduce metabolic rates. Drugs such as anxiolytics and sedatives can work here. To produce hemodynamic stability, clonidine in the past was used on hypertensive patients, but nowadays it is no longer in use. Control of infection. Drugs used here are basically for the control of infection, usually given 60 minutes before skin incision. This is so adjusted so that peak blood levels are achieved at the time of skin incision. Some of the drugs are antibiotics like ceftriaxone, ampiclox, to mention but a few. Blunt unwanted vagal reflexes. The pre-medical drug use depresses reflex sympathetic activities, intubation, and laryngoscopy, especially in patients with ischemic heart disease, increased intracranial pressure, and hypertension. The drug of choice here are B1 elective adrenergic antagonists like the esmolol and atenolol. Also, anticholinergics such as atropine can be given to reduce excessive secretion, which can increase the vagal reflexes. Reduction of post-operative nausea and vomiting. This is especially for patients that are at high risk of post-operative nausea and vomiting, which is associated with the administration of opioids before, during, and after anesthesia. Also, for some procedures that are with high risk of post-operative nausea and vomiting, such as ophthalmic surgeries, ear, nose and throat, and gynecological procedures. The drugs used here can also be given to patients of the female gender, non-smokers, obese patients, those with previous history of post-operative nausea and vomiting, those in pain, those with gastric distension, and those that have been given anesthetic agents. The drugs used as anti-emetic prophylaxis are butyrophenones such as haloperidol, droperidol, domperidone. Also, we have phenothiazines such as promethazine and trimethoprim. Others include anticholinergics like iosine, also 5-hydroxytryptamine antagonists such as palonosetron, graniserone, and ondansetron. It is worthy to note here that the American Society of Anesthetists, ASA, does not recommend the preoperative administration of metoclopramide for the prevention of post-operative nausea and vomiting. No. Also, we have other co-administered drugs that are used to optimize patients. Basically, these are not really essential, like it's not a general thing for all patients, but specifically for those patients with certain disease conditions, like those that are hypertensive, getting their antihypertensives prior to surgery, maybe on the morning of surgery, those on anticonvulsant therapy getting their drugs till the morning of the surgery, patients on steroid therapy that have received like 3 courses of the drug within 3 months get a booster dose of steroid prior to surgery and all that, like anticoagulants for patients that have high risk of developing deep vein thrombosis during surgery to facilitate smooth induction of anesthesia and to reduce the amount of anesthetic agent used during surgery. You may want to give drugs like benzodiazepines like diazepam, analgesics like pentazocine and all that, so that you don't need to go about using much of your anesthetic agents such as ketamine, propofol and all that. I hope you found this content useful. If you do, or if you did, please share with your friends, share with your colleagues. I'd like to see your comments, your questions. Please drop a comment on the comment section. I'd like to see them. Thank you.